Today's podcast is covering the anatomy, biomechanics, and kinesiology of the forearm, wrist, and hand. There's a few objectives as we get started. Specifically, we're going to be looking at some of the joints, the ligaments, different musculoskeletal components, as well as describing the biomechanics. We'll look at some general organization and functional positions of the hand, as well as describe and discuss the significance of surgical no man's land. And then we'll also talk about some of the static and dynamic stabilizers of the wrist and hand as well. Now, additional reading can be found in Dutton's 4th edition text, specifically chapter 18, as well as other kinesiology texts such as Neumann and Oatis. As we get started, let's appreciate some of the osteology of the wrist and hand. We have the distal radioulnar joint, as well as the radiocarpal, midcarpal, intercarpal, carpometacarpal, and then carpometacarpal phalangeal into the interphalangeal joints. Lots going on in the wrist and hand. And it's because of all these joints that we have the mobility that we have. We have the dexterity, we have the fine motor control, we have the grip and the functional position of the hand, right? So really the hand is designed to enable us a good deal of control and movement. Some things that we should note. Number one, on our radial side is where we find our scaphoid, which articulates with the trapezium. Then we have, moving more towards the middle, the lunate, and then finally the triquetrum. Additionally, we find the pisiform, though pisiform is only palpable on the volar aspect. And then we come back to the more lateral side again. We see trapezium and trapezoid. Finally, capitate, which is the large kind of central bone to the distal row, and then finally hamate. That all articulates then with our metacarpals and the metacarpal phalangeal joints, MCPs leading out to the individual digits. Now again, we have multiple joints, so it's important that we acknowledge these. First, we have the distal radioulnar joint. Additionally, we find our radiocarpal joint, and then the mid or intercarpal joints. Additionally, we have the carpometacarpal joint. And so if we go a little bit further out, we have the metacarpal phalangeal and interphalangeal joints. So there's lots and lots that's going on in the wrist and hand, again, contributing to the vast array of functional movements and demands that we see at this region. This is from Cleland's Netter's Anatomy. It's helpful for discriminating the type and classification. You'll note that most are plain type synovial, with the exception of the MCP being condyloid, as well as the radiocarpal. Additionally, the first CMC is kind of an interesting joint as well, though not specifically captured in this graphic. You'll also note that the capsular pattern is limited in each direction equally, with the exception of the interphalangeal joint. Now, if we zoom in just on the wrist, there's a couple joints that we find. First, we find the radiocarpal joint. Then we find the intercarpal and the midcarpal joint. So first, let's talk about the radiocarpal. The radiocarpal is really what we might define as the wrist joint. Approximately, it's made up of the distal radius as well as the TFCC, otherwise known as the triangular fibrocartilage complex, that really adds some stability and binds the radius to the ulna, enhancing, again, the static stability. Distally, we find the scaphoid articulating with the first metacarpal, the lunate more medially, and then finally the triquetrum, and it's classified as a modified ovoid or condyloid joint as a whole. Now that TFCC is kind of an interesting structure, so let's look at that just a little bit further. It is a disc, if you will, an articular disc that exists between the ulna as well as the lunate and the triquetrum. Again, it's a primary stabilizer, kind of binding the radius to the ulna. And just like we see at the glenohumeral joint with this bit of fibrocartilage, it enhances not only the stability but also the joint congruency. And so it enables, in essence, the wrist to have a little bit more ability to dissipate force. The radius bears about 60%, though the ulna will bear about 40%. And If the TFCC is injured or removed, then from there, you'll see a significant shift towards the radius in terms of total kind of bearing of weight and force. Now, the intercarpal joints are interesting because each one of these is really a plane type synovial joint with small movements that contribute to the greater whole of wrist range of motion. So while each one is rather small, they have a pretty profound effect overall on the totality of range of motion. And so together, they help to improve wrist flexion and then also wrist extension. Now, stability-wise, they're bound together by these small intercarpal ligaments that really only allow minimal gliding between the bones. So when we do our arthrokinematic or manual assessment, we look at this in terms of rows. Now, granted, we can look one carpal on the next, but really it's quite challenging to just focus on one and not get kind of what we would call concomitant mobility in the surrounding or adjacent carpals as well, primarily due to those intercarpal ligaments that are holding everything and binding everything together. As we move from the proximal row into the distal row, kind of in between, we find the midcarpal joint, and it is between the proximal row, that being the scaphoid, lunate, and triquetrum, and the distal row, the trapezium, trapezoid, capitate, and hamate. Good way to remember this, while perhaps maybe not the most politically correct, the mnemonic, some lovers try positions that they cannot handle, is kind of a nice way to keep straight which bone is which. Now, we have dorsal and palmar ligaments here, but they are more to kind of hold things together than to really enhance stability. So we find that there's lots of mobility between the carpal bones, again, helping to contribute to flexion extension, even some radial and ulnar deviation. Now, the distal radial ulnar joint is a uniaxial pivot joint, and really this is where we find pronation and supination. The interosseous membrane is probably the strongest of the three ligamentous membranes here. We also have a dorsal and palmar ligament, but the interosseous really provides most of the strength. It should be noted as well that in a supinated position, the bones lie in parallel. When we pronate, the radius will actually overlap the ulna, and that's an important point because it's thought that that contributes to the distal radial fracture when you fall on an outstretched hand, either in a flexed or extended position. Again, reminding where we find all of our individual joints and labeling them such that we can appreciate them. We've been talking a little bit about the ligaments of the wrist. Here you can find that interosseous membrane as well as some of the volar and dorsal ligaments. It should be noted there's a significant amount of palmar radiocarpal ligaments, as well as additional kind of intercarpal ligaments holding things together. On the opposite side, the right hand side, we can see some of the dorsal ligaments. You'll note that the dorsal ligament, just in terms of totality of space, is far less. And then we can begin to view some of the ligaments that expand out into the phalanges themselves. And so here's where we begin to see some of the collateral ligaments, some of the palmar plates that can create potentially some issues later on that we'll look at with differential diagnosis, as well as some of the ligaments that make up our interphalangeal joints, specifically our collateral ligaments and the joint capsules as well. It should be noted all these are static stabilizers, whereas the extensor muscles of the wrist and hand and the flexor muscles of the wrist and hand would be more the dynamic stabilizers. And so the extensor muscles of the wrist and hand really arise from the more lateral epicondyle, the common extensor tendon, and then moving down into the wrist and hand. Arguably, one of the big ones that's actually proximal is the extensor carpi radialis longus. We then also have extensor carpi radialis brevis, ECU extensor carpi ulnaris, and then finally extensor digitorum and extensor digiti minimi. Additionally, as we move into our first CMC, these are structures that are associated with our anatomical snuff box, we see extensor pollicis brevis and longus, as well as abductor pollicis longus. APL and EPB are really the two that are associated, though, with our anatomical snuff box, or the first CMC. If we look at the flexor muscles of the wrist and hand, these arise or emanate from the medial epicondyle and the common flexor tendon. The big ones that we see are the flexor carpi radialis and flexor carpi ulnaris, as well as palmaris longus. We can also see flexor digitorum profundus and pollicis longus as well on this image. Now, as we move down, specifically looking at the extensors and flexors, first looking at the extensors, in order to prevent what's called bowstringing, which is in essence where the tendons lose some of their mechanical advantage, there is the extensor retinaculum that really kind of binds and forms a protection for those tendons such that they can maintain a good line of pull, right? And so the retinaculum and then the underlying bones really form what are called tunnel-like structures, right? And so this is where we find all of our extensor structures. In each of these compartments, we have a number of tendons. These are important if you are a surgeon that's looking to maintain these. If you are a physical therapist, nice to know, but more from a broad kind of general standpoint. On the opposite side, the volar side, is where we find the flexor retinaculum. It serves a similar purpose to kind of create a stabilizer such that it minimizes bowstringing, but interestingly enough, it also serves as the roof of the carpal tunnel. And so it attaches to the pisiform and hook of hamate, transverses across to the scaphoid tubercle, as well as the trapezium, and then really serves again as that roof. So it protects the median nerve, it protects the carpal tunnel, as well as maintaining the carpal arch, such that there is a tunnel for these structures to move through. And it is made up of the carpal ligament as well as the transverse carpal ligament. In this image, then, you can see the flexor retinaculum blending with the transverse palmar ligament and into the palmar aponeurosis, as well as a nice axial view of the carpal tunnel, which is where we see what is actually contained within the carpal tunnel. So deep to the flexor retinaculum, we see flexor digitorum superficialis, we see flexor digitorum profundus, we also see our flexor pollicis longus and our flexor carpi radialis. So again, we see our carpal tunnel here. We have a couple different contents that pass deep to that flexor retinaculum, as indicated on the last slide. Over the top, though, we have a couple things that are not within the carpal tunnel. Most notably of the palmaris longus that's commonly utilized in a Tommy John surgery. We also have our ulnar nerve and artery that would fall kind of on the more medial aspect, passing through Guyon's canal, and then also the sensory branch of the median nerve. Now, this is important because if an individual has a pathology, if you will, of the median nerve, that's found within the carpal tunnel. However, the sensory branch of the median nerve is not. Okay. Now, I mentioned Guyon's canal, or the tunnel of Guyon. This is superficial to the flexor retinaculum and is really between the hook of the hamate and the pisiform bones. And it serves as this passageway for the ulnar nerve and ulnar artery. It's more superficial than our median nerve, and it can become a site of entrapment for individuals who are experiencing signs and symptoms into the fourth and fifth digit. Now, as we move into the wrist and hand, we begin looking at the CMC joints, or the carpometacarpal joints. Their stability is provided due to the dorsal and palmar ligaments, and the function really is to provide gliding. We have less movement in the second and third, more in the fourth and fifth. That is primarily to allow us to grasp things, to grip things. In terms of 2 and 3, that's far more for stabilization, capsular patterns being equally limited in all direction. For the CMC joint of the thumb, then, we noted 2 and 3 less, 4 and 5 more, but one of the CMCs is pretty important. That is the saddle joint. It is an articulation that occurs between the trapezium and the first metacarpal. It moves more easily and into more of a functional position, that being opposition. It helps with prehensile grip, and its function is to help not only with flexion and extension, but then also with abduction and adduction. So it's a very, very mobile joint, such that it can help again with grasping and gripping. To remind everyone what we see, flexion and extension are kind of across the palm, whereas AD and abduction are toward the first digit and away from the first digit, right? So abduction is what we might call in the plane of the fingers, right? Whereas thumb and flexion extension of the thumb, or first CMC, is more in the plane of the palm. Now, we have several joints here associated with the metacarpal phalangeal joints, moving away from the CMC now. And with these articulations, we have a convex head that's really associated with the metacarpal, and then a concave base that is associated with the proximal phalange. Again, earlier we noted the static stabilizers are the collateral ligaments. This is true for all of these, and we find flexion and extension here, but then also a degree of AB or adduction, or we might even say ulnar or radial glide. And this again helps with regards to widening our grip or making it far more narrow. If we move further, we find our distal interphalange and proximal interphalange joints, the DIP and PIP. Similarly, we have a convex head and a concave base associated with the middle phalanx, 2 through 5, and then the distal phalanx. Just as we saw before, we have capsules, we have collateral ligaments, as well as palmar ligaments. And the palmar ligaments tend to be a bit thicker, as you saw earlier in some of the graphics. Now, should something happen to the hand where we would need to splint, it's important that we recognize the functional position of the hand. The functional position of the hand is also referred to as the resting position of the hand. And so if someone needs to be splinted, or there's a burn where there could be scar tissue formation, this is typically the position they will splint them in, such that it is in a mid-range position, but it also prevents contracture formation. Now, Carol Oatis provides a nice kind of overview of this position of function of the hand, and notes that the hand is in the position of function with a very small amount of motion in the thumb and fingers that could be useful with regards to pinching and grasping. She also notes that there's a close relation of the tendons to bone, such that the flexor tendons are held close to the bone, as well as with the extensors. Now, range of motion, specifically with wrist movement, is somewhat controversial. In some texts, extension is more at the radiocarpal, less at the midcarpal. In others, it's switched. Flexion can be the same, but really we need to recognize that both flexion and extension occur at not only the radiocarpal but also the midcarpal joints. So if there is a limitation either at the radiocarpal or midcarpal, we will see an impact on the ability for the wrist to fully extend or fully flex. We have to have movement in both joints in order to have full range of motion. Overall, the general organization for the wrist and hand is really divided based off of deep and superficial, as well as radial and ulnar sides. Additionally, we use a slightly different nomenclature here, such that we refer to the palmar aspect as the volar or ventral side. The back of the hand is the more dorsal side. It also can be referred to as anterior to posterior, though we need to recognize that this is in regards to our normal anatomical positioning with the palms facing forward. When we're looking at the ligaments, we've already noted that the ligamentous support is provided both dorsally and volarly, along with these intermetacarpal ligaments. So we have carpometacarpal ligaments, we have inner metacarpal ligaments. Additionally, we have ligaments that support the first CMC. We have the inner metacarpal, the ulnar collateral. UCL ligament is one that is oftentimes disrupted at the first CMC, specifically with gamekeeper's thumb. And then we also have the radiocollateral ligament as well. Now, earlier I made note of the inner carpal ligaments. These are ligaments that support the metacarpal phalangeal joints, as well as connective tissue structures such as we find with the joint capsule, and then the volar or palmar plate. Now, those are important to recognize and note because we'll see some pathologies associated with the phalanges later in differential diagnoses where disruption of that palmar or volar plate occurs. Additionally, with our intercarpal ligaments, we see scapholunate as well as lunotriquetral. This is important to recognize because we can have what's known as VISI and DISI, which are intercarpal disassociations. DISI, dorsal intercarpal, is associated with scapholunate. A VISI would be associated with lunotriquetral, though it's far more rare. On the interphalange side, again, we've noted those palmar plates. The other aspect that's easy to appreciate here are the collateral ligaments that help to maintain stability left to right or ulnar to radial. Now, the extensor hood and the flexor pulley mechanism get a lot of attention, and rightfully so. The extensor hood is really a remarkable design. And at the MCP joint, we have this tendon of the extensor digitorum that fans out to cover both the posterior aspect and like this hood structure. And the distal tendon then is going to receive additional tendons from both the lumbricals and the interossei, which help to spread the fingers and bring them back together. In doing so, it provides this cable-like system that allows for the MCP and IP joints to extend, but also for the lumbricals and interossei to assist in flexion of the MCP joints. Conversely, on the volar side, we have the flexor pulley system, and this helps to, again, allow us to flex our fingers, but without bowstringing, and you'll see this in just a second when we talk about the pulley system. Now, the pulley system is really important for this idea of bowstring. Bowstring is, in essence, where we would lose some of our mechanical advantage in line of pull. As such, we need both the annular ring pulleys as well as the cruciate or cross pulleys. The annular ring pulleys are associated with the synovial joints. So we have A1, 3, and 5, that being the metacarpal phalangeal, the proximal interphalangeal, and the distal interphalangeal. A2 and 4 then are related to the proximal ends of the proximal and middle phalangeal shafts. The A2 and A4 are the critical pulleys. They're thicker, they're longer in terms of the annular pulleys, and they have a bigger role in preventing bowstringing. So if there's a deficiency of even 25% of either of those critical pulleys, it's much more likely to result in bowstringing. The cruciate or cross pulleys, C1, sometimes as much as 4, are beneficial. They are related to the distal phalangeal shafts, and so while important, they don't elevate quite to the level of A2 and A4. So let's give you a graphical illustration of what this may look like. So here you see an intact pulley system, A1 being associated with metacarpal, A2 proximal phalanx, so on and so forth. Remember, we said A2 and A4 are the most important, if you will, functionally. And so if A2 would be compromised, you would have a ruptured pulley, you would lose the mechanical advantage or the line of pull, and you would end up with a bowstringing effect, right? And so in essence, you would lose kind of the ability to fully extend the distal phalange, both proximal interphalange as well as distal phalanx. So it illustrates here when bowstringing, it's about 58 degrees of phalanx flexion. Without bowstringing, because the intact pulley, it's more than double at 115 degrees. Now, there are some synovial sheaths as well. These are important because we can have what's known as tenosynovitis. We can also end up with bursitis and other inflammatory conditions that could reduce the mobility and overall kind of sliding of the tendons within these sheaths. There are individual tendon sheaths for the second, third, and fourth. Maybe the fifth digit, there's a little bit of debate on that. And then also we find the radial flexor synovial sheath for flexor pollicis longus. The palmar aponeurosis does need to be mentioned, as we can develop some issues here, specifically related with contractures associated with Dupuytren's hand or the benediction hand. It's very dense and fibrous. It's continuous with the palmaris longus, as well as both the thenar and hypothenar eminences. There are essentially 4 slips from the central region that continue toward the phalanx, and they will kind of wrap around the respective tendons, those being the flexor tendons. Now, positions for the wrist and hands are associated with the arches of the hand. Those arches are very important for grabbing and grasping objects. We have a longitudinal arch as well as a proximal and distal transverse arch. The proximal transverse arch is associated with the transverse carpals. The distal transverse is associated with the metacarpals, and that kind of makes sense if you just think about this. The first arch, if you're looking at your hand, is really at the base of the thenar to the hypothenar eminence. Well, that's closer to the carpals. Distal more at the MCP. Illustrating the need then to grasp and grab and use these prehensile motions, tip pinch, tip to tip, lateral prehension, kind of the chuck or 3-fingered pinch. So a number of different postures and positions that the hand needs to adopt. Additionally, we have palmar creases. This is where we find the border of the flexor retinaculum as well as the flexor tendon sheath. These are really where the fascia has adhered to the skin underneath, and so they indicate where movements may occur at the wrist joint, right? And so this also gives us an idea of where we are in the wrist. The distal wrist crease is really the proximal border of the flexor retinaculum, and then the proximal is where we find the flexor tendon sheaths. We can also see the palmar creases. Now the palmar creases get a fair amount of focus in terms of palm reading. They at one point were thought to be associated with the heart line, the head line, the life line, things along those lines. Really, they are where the hand is going to bend and move to allow for overall, again, grabbing and grasping. One kind of anomaly is what's referred to as the simian crease. Normally we have 2 palm creases. If we jump back for a second, you see that's the heart and the head, otherwise known as the distal palmar or proximal palmar. A simian crease is noted really if you are into some of the more palm reading and different ideas there. Finger creases are also available, distal, middle, and proximal. They tend to associate with the MCP, PIP, and DIP joint. And then while we're talking about fingers, we should note the anatomical snuff box. Again, the anatomical snuff box we mentioned earlier is associated with the first CMC. This is where we find specifically the extensor pollicis longus, as well as extensor pollicis brevis, and then abductor pollicis longus. Now, for this, we have a couple of structures that cross this area. We have the radial artery and the superficial branch of the radial nerve, as well as then our extensor carpi radialis longus and brevis. The borders, the 2 main tendons that are associated with this would be the abductor pollicis longus and then the extensor pollicis brevis. Right, the base is the first metacarpal bone, that being also then associated with the trapezium, and then the floor is the scaphoid and the trapezium, notably the scaphoid. Now, as you've probably realized, there's a whole lot going on at the wrist and hand in terms of muscles and tendons. We have 19 intrinsic muscles located entirely within the hand. We have 24 extrinsic muscles, meaning the muscle bellies lie proximal to the wrist, but then originate in the forearm and then insert distally in the hand. The reason for this is we want to provide a lot of action and use for the wrist and hand without a lot of excess bulk. Right. Additionally, we can enhance some of the stability by utilizing and relying on some of these tendons to help to compress the carpals and again provide dynamic stabilization. We've talked about most of these already. These graphics that are included in the slides are really for your use. As a refresher, you can see both the flexors in this image from superficial all the way down to deep. And in this image, you can see and appreciate the extensors as well as some of the elbow flexors. As we move into the wrist and hand, this is where we find our intrinsics, things such as the interosseous and lumbrical soft tissue, as well as our ponens pollicis, ponens digiti minimi, our abductor pollicis brevis, and ponens digiti minimi, and other like muscles. This graphic gives a nice illustration of the three named nerves that course through the forearm into the wrist and hand, primarily the median nerve, which comes through the antecubital tunnel, the ulnar nerve coming through our cubital tunnel from the posterior medial aspect of the elbow, and then our radial nerve, which comes across that more kind of anterolateral portion of the lateral epicondyle and then courses down into the forearm and wrist and hand. Now, radial nerve entrapment can result in a loss of thumb extension at the wrist as well as overall wrist extension, since the wrist extensor muscles are synergist and stabilize the finger flexor muscles during gripping. This loss significantly hampers hand function, right? So if someone is dealing with a radial nerve pathology, it certainly is worth exploring the impact that that may have on the wrist and hand. Vasculature of the wrist and hand, we have the radial artery and the ulnar artery primarily. The radial artery primarily innervates and sends blood supply to the more lateral portion. Ulnar artery is to the more medial portion. And then finally, we want to talk about surgical zones. Surgical zones are important for us to be aware of as we deal with the rehabilitation. Surgical zones are really for tendon repairs. We have both palmar and dorsal zones, and they're important that we recognize what structures are included within each zone as well as the type of surgical intervention or healing time that exists there. On the extensor side, we have a total of 8 zones. On the flexor side, we have a total of 5 zones. Now, a couple things to note, specifically on the flexor side. Zone 5, proximal, this is the wrist area. Muscle contractures occur very quickly there, as well as we can get neurovascular injuries. Zone 4, CT region, this is tendon and neurovascular, things like that. Zone 3 actually has a pretty good prognosis. Right? It's the palmar region. Now, zone 2 is what's referred to as no man's land. Okay? No man's land because this area has a very poor blood supply, and it's very easy to begin to develop adhesions within the synovial sheaths, the tendon sheaths, and flexor digitorum brevis flexor digitorum profundus and flexor digitorum superficialis typically are severed in this region as well. Okay. It should be noted that A1 is a primary pulley associated with zone 2. Right? A2 can be as well as you move distal, but A1 would be the first associated with zone 2. This gives you another view of that surgical no man's land, that being zone 2. Blood supply is typically good in the other zones. Again, we have 2 predominant zones for the thumb, and then 5 for the wrist and hand. And then finally, we look at the dorsal surgical zones. I mentioned previously there are 8, 5 for the thumb, so a little bit different here. The dorsal blood supply is not as good as what we see on the palmar or volar side, and so if there is dorsal pathology, it oftentimes requires a little bit longer healing due to that reduction in blood supply. So that wraps up our review of the anatomy, kinesiology, and biomechanics of the wrist and hand. Spend some time with the slides. It's not necessary that you get into the weeds on too much of this. Certainly, if that is an interest of yours, there are certifications such as CHT that would enable you to kind of go down some of these rabbit holes. But certainly appreciate that we're dealing with a variety of joints, a variety of soft tissue, both intrinsic and extrinsic, and fairly intricate mechanisms between the flexor and extensor hoods. So have a review of this information, and certainly let me know if there's any questions.